thank you for joining us today. ICI is hosting this month, but we thought it would be great to have David talk about something that's been really important to us in the past couple months and something that we've been working with David and as a tech member on, and then he had this great idea of also having Bob come and speak with us about the experience from immunization programs. But as you saw from the email, the topic is minimizing unintended harm associated with mass drug administration.
Thank you very much. Well, let's jump in to this. Yeah, this is a topic that has been of interest to me and has now been important for ITI, and so I wanted to raise this issue of unintended harm and the issue of mass drug administration safety, and to help us interpret this and to help us maybe think in different ways about safety in our interventions with mass drug administration, we've invited Bob Chen, who's recently joined the task force with the Brighton collaboration, and who spent his whole career in vaccine safety, to give us some contrasts and compare how the vaccination folks look at this whole issue and what we might learn from them. So we hope to have a conversation sort of comparing and contrasting these two fields of health. We basically in global health have two main ethical obligations. One is to deliver benefit, and the term for this is beneficence. And the other is to minimize harm, and that's called beneficence. So we deliver benefits to the whole population, but sometimes individuals are harmed. And how do we balance these competing goals? Mass drug administration actually delivers benefits to both individuals and populations. It's the most effective way to reach people who are infected with the diseases we work with, and it has a population benefit in reducing transmission. We're here at the task force intensively with 4 of those. We deal less frequently with schistosomiasis. The benefits of mass drug administration for these NTDs is just unquestioned. I mean, so this is not an issue of saying, are we delivering benefits? That is not the issue here. The benefits are massive in terms of reduced human suffering, reduced infection, and actually stopping transmission or interrupting transmission in certain areas. So 1 billion people are being treated every year, and massive benefits are being realized through mass drug administration. But occasionally, people are harmed, and the harm that I want to focus on today is one that was first published in 2007 by the World Health Organization in this document, and they noted that 4 children under the age of 36 months had died from choking for soil-transmitted helminths. When I was director of worms, I heard about repeated instances of or children choking to death on albendazole or the deworming drug, and the surveillance system for this was not necessarily sensitive to pick all of these up. Sometimes we heard of these through the media and through other avenues, and we sort of scrambled to figure out what actually happened and what the circumstances were. And as you can imagine, events is often quite difficult. WHO has offered some guidance on this through the years. In 2004, it had recommendations to crush between 2 spoons. I don't know if any of you have never eaten. It's not a very good way to crush the albendazole. And then to give a glass of water for who? For children that have difficulty swallowing. So some pretty vague recommendations. In 2007, in the document that I just showed, they said, well, break the tablet into pieces or crush them, give it to young children. No guidance on the age. Again, in 2007, there was a newsletter, not an official WHO document, called from the Partnership for Parasite Control, And it provided more guidance. It said for children under 3 years, the tablet should be broken and crushed and then water added. Okay? So this was the most complete information, but it wasn't an official WHO document, and therefore it received limited distribution. 10 years later, we did an evaluation with some students in Notre Dame to actually observe deworming and see are tablets being crushed, what are the practices, what's the risk of choking, and we worked with a group called Vitamin Angels, as you see here, and they basically observed these mass drug administrations for the preschool-age children. What they found was that almost a quarter of children 12 months to 35 months of age received whole tablets, so that they were not being crushed. And when they were being crushed, they were often, the two-spoon method wasn't being used. Another with a Coke bottle or a hammer, a rock, and then pour the crushed tablets into the child's mouth. That was being used by some. But you can see one of the challenges here, this child really doesn't want to take this medication. Okay? And this was something that really came out in the analysis. We looked at what were the factors associated with non-fatal choking. About 1% of these children had a choking episode. The only thing, multivariate analysis that being significantly associated with choking was the child being fearful, fussy, or combative, basically not wanting to take the medicine. And these children had a 20-fold increased odds of having a choking event. They didn't observe any fatal choking, but these were choking events that in some cases completely obstructed airflow for a few seconds. 18% of children fit this definition, or fussy or fearful or combative. Now, if we look at the broader NTD sort of portfolio, moving beyond STH, there's a couple factors that seem to be important to consider. One of these is the age of the child, and the other is the size or the formulation of the tablet. This is a graph showing the diameter of the trachea, the windpipe, by age. And you can see in children, say 6 months of age to 1 year of age, the average diameter is less than 4 millimeters. This is very small. Whereas in children 4 to 6 years of age, it's about 6 to 7 millimeters. Still quite small. Okay, so the younger the child is, the greater the risk of choking, not only for physical reasons, but also because they don't have teeth and they may not be able to chew and those sorts of things. So the age at which the drugs are recommended will also have an influence here. For trachoma, the recommendation is to treat children as young as 6 months of age. For STH, it's down to 1 year of age, 12 months. So it's a little bit more complicated. It's based on height and that sort of thing, but around between 4 to 6 years of age. And then schistosomiasis treatment is offered for children 6 years of age and older. Okay? So the closer you are to this end of the spectrum, the more problems you might have with a given size tablet or formulation. This is a busy slide, but it shows the different NTDs and the different drugs and the dimensions. It's very difficult to find out how large these tablets are. It's not published in the package, so we've had to track them down. I've bothered many of you for these tablets, and we've tried to measure them. And this is not, don't take this as the most accurate data, but this is the best we can have. You can see that for it's relatively small, and it's flat, by 6 by 6. Albendazole, 6 by 19 millimeters, much, much larger than the diameter of the trachea. And even at the smallest dimension, for a 1-year-old child, you're larger than the trachea. It's chewable, but what if the child doesn't chew it? Or what if it's forced down the child's throat? It's tablet, smaller than albendazole, but Pfizer provides an oral suspension, unlike the other manufacturers. So this is how Pfizer and the ITI gets around this problem. Okay? Why are we concerned about this? Well, we've not been as concerned about choking as we've been concerned with other things in mass drug administration. My sense is that there's been a massive scale up of mass drug administration, as you know. There's increased visibility and scrutiny of NTD programs compared to, say, 10 years ago. There's been increased awareness of choking-related deaths. And I think there's an increasing concern for reputational risk among the different partners, particularly among some of the manufacturers of the drugs. And there's been recent scandals in humanitarian organizations, Oxfam and others, that have highlighted the need for global health and humanitarian organizations to protect and safeguard child well-being. The response to this increased concern, at least by ITI and Pfizer, has been to revise the dose guidelines and to make the liquid oral suspension available to children not only to 5 years of age, but increased to 7 years of age. And there's also a height increase in height that has now been approved. The oral suspension is also available to anyone who has trouble swallowing, okay, regardless of age. The Trachoma Expert Committee last year recommended as a goal 0 serious adverse events due to choking. So it's not just the goal of how much coverage we're going to have or how many tablets we're going to distribute, but a goal of avoiding harm. And I think this is, was a very interesting milestone for the tech to take this step to not only set goals for beneficence, but also for non-maleficence. There's been several conversations among different partners, WHO and elsewhere, and recently there was a safety consultation on MDAS in Ethiopia that I was privileged to participate in. I just want to share one slide from that consultation about different methods that came by community drug distributors. If a child is fussy, provide a space for that parent to calm the child down. It may just take a few minutes to calm the child down away from the intensity of the distribution site itself, but within view of the health worker. Never force a child to take medication. Don't hold the child's nose. We see this a lot. Try to force them to swallow. Don't force the child's head back like this, which just opens the trachea and gives it a straight shot for the tablet to go down the trachea or the windpipe. Encourage the child to take the medicine. Fortunately, the Zithromax syrup tastes very good, and if you could put a little drop on there, they say, oh, let's have some more of that. You can try your siblings first so that the child can see that this is something that's good to do. And if they fussy, just try again on another day. We have a lot of challenges in addressing mass administration safety. Wanted Dr. Chen to come tell us about vaccine safety. We lack data on the actual practices. How many children are still, how many children in trachoma are getting tablets rather than prevention? How many tablets are actually being crushed? We don't know. How many non-fatal choking events occur and what are the risk factors? Other than that one study, we don't have data. We have very poor data on the circumstances of these choking events, and so it's very hard to develop preventive strategies. There's this massive training cascade. Even if we had these messages, even if these messages were effective, how do we get them in the training cascade down to the local level where those messages or practices are actually implemented? Our primary focus has been to scale up mass drug administration, achieve high coverage, reach WHO goals. And there's a sense that, boy, if we're too concerned about safety or we're excluding children, we might not reach our targets. There's also a fear that even by talking about this, we might be threatening the global programs that will make the donors skittish or that will raise the potential for lawsuits. And so that's also been a challenge for us as a community. So I think we can learn from the vaccine community, which has spent a lot more time, energy, and attention on this issue of harm and have been able to talk about it in ways that have been helpful, but also, as you see in the news now, there's big issues related to vaccine safety and perceived safety that still the vaccine community is wrestling. Look forward to talk, and then when Bob's done, we'll have a general conversation. I'd like if you could hold your questions for me until after Bob's talk. Thank you.
Thank you, David.
Well, let's see. And I should point this towards, okay. Oops, let's see. Okay, there we go. All right. As David said, I'm brand new to the task force, though I was at CDC for 30-some years, working mostly on this topic, and so hope to be able to share some information that's useful to you. So now being an ethicist, I'll present some of the beneficence alternative framework. So we about balance between benefit and risk of any intervention, benefit being efficacy, convenience, kind of longer life effects, risks being safety and tolerability. We talk about this kind of in the same breath. It turns out that scientifically, methodologically, it's much more challenging to measure safety in contrast to efficacy. So efficacy is actually very straightforward. You measure the difference in disease rate between people who get the drug or who get the vaccine compared to people who don't. It's a straightforward mathematical calculation. Safety, on the other hand, cannot be measured directly. It can only be inferred indirectly from multiple different adverse events that you actually measure, and from their relative absence, given the sample size you looked at, that you infer indirectly whether something is relatively safe or not. And methodologically, that is like orders of magnitude much more challenging actually to establish if you were really serious about doing that. And in each domain, there's kind of lingo, and so in the immunization field, we talk about called ADVI, and stands for either adverse effect or adverse event following immunization. And in general, we use the term caused by being incident that we don't know for sure. It could be coincidental or could be causal, and people kind of use AEFI and vaccine adverse events kind of interchangeably. Decisions of large numbers, consequences are obviously greater than clinical medicine, where decision times are just kind of one patient at a time. General immunization, it's a preventive intervention, so the vaccinees are really healthy. Contrast to people who are sick already and therefore are being treated with some kind of medication for that illness. And then larger vaccination frequently universally recommended or mandated. Tolerance relate mathematically into the need to search for more rare reactions. So for cancer and you chemotherapy, your side effect is essentially 100% success in terms of the pre-vaccine era, large numbers, and then kind of recent years close to 100% reduction. But the piece that people usually don't talk about, and despite arguing for this for many years without success, is actually this line here in terms of the vaccine adverse events. So we've gone from none in the pre-vaccine era to a recent year of almost 12,000 reports of adverse events after vaccinations against these specific diseases, and then a total reports, and this is all passive reporting, which is obviously even underreporting, of close to 39,000, including all other vaccines as well. Now, historically, immunizations programs talk about their goal of kind of eliminating and reducing these targeted diseases, but I argue that we should also have a goal, try to eliminate these adverse events, at least the ones that are truly caused by vaccines, if we are equally balanced in what our goals are as a program. Now, the field is part of the controversy that we hear these days is due to this inherent problem. Those of us in public health and medicine look at this issue inherently in a horizontal manner, whereas those people walking on the streets outside who are not in public health or medicine inherently look at this issue from a vertical manner, that they're just as likely, or their child, etc., to have an adverse event compared to encountering a wild disease. Now, obviously, right now, with the resurgence of measles, these numbers are going up. But this point is just simply highlighting the inherent kind of cross-communication in the field, that people working in public health kind of instinctively think that the people out there should see this from the horizontal perspective, when in reality they actually experience it in the vertical perspective. And this is kind of just highlighting one example of this. Most of you are probably familiar with the polio vaccine, which comes in two versions. There's an oral sugar drop that you as a child, and then an injectable form. Now, the problem with the oral form is that in a rare situation, let's say kind of the order of kind of 1 per million or that order, the virus will revert back to what we call the wild type and actually cause the paralytic polio in the vaccinee or the family or members. And so back when we get to the kind of mid-1970s, basically we had gotten rid of the wild polio, and all the cases every year were due to the vaccine. And the former director of the U.S. immunization program realized that in 1996, the patients group got organized and actually came to the meeting en masse with all these people in wheelchairs who were paralyzed, etc., to demonstrate that they were more than numbers, that they were in fact real people who suffer the consequence of this vaccine. And so whereas the vaccine establishment up till that time were very much in favor of using the OPV rather than the inactivated form, which was like 10 times more expensive, required injection, etc., upon encountering all these kind of real faces, if you will, Dr. Walt Ornstein, director of the program, realized that he needed to make a change in the recommendations. So this is kind of a evolutionary, a slide showing the evolution of immunizations, where access the maturity of the immunization program in kind of 5 different stages. And on the y-axis, you have incidence of 3 different things, kind of the incidence of disease, the coverage, and the adverse event. So in the pre-vaccine era, obviously all you have is a high rate of disease. Once you have a safe and effective vaccine that is licensed and coverage increases, the disease comes down. But you also have an increasing number of adverse events, both true reactions and coincidental events that are blamed on the vaccine. At sustained high coverages, the 2 lines approximate each other, in which case and it's easy for a media scare to occur, and then you have a loss of confidence and resurgence of the wild disease. Now, with a few diseases, classically smallpox and now perhaps polio, the thought is that you could actually eradicate the disease, stop the vaccination, and that time also eradicate the vaccine adverse events. And so that was actually what happened with smallpox. Now, the problem is that that occurred in a era of innocence, and some might argue naivete, because in this era of bioterrorism, even if we eliminated the disease, it's a good question as to whether we would actually afford to stop vaccination. Because if you hearken back to the era of the great explorers, Columbus and all the others, various native populations around the world were decimated by the introduction of measles and smallpox because they didn't have that immunity against these diseases. And so for us to stop that vaccination would actually make us vulnerable, and one would argue that's probably not a good idea. So that means that there are very few diseases, if any, that will be eradicable, and that means that all immunization programs and their managers are going to be stuck in this very uncomfortable position of high coverage, relatively low disease rate, and prominent adverse events, and waiting for that next loss of confidence. So the only way forward is actually to figure out which of these adverse events are truly due to vaccine, and are there ways to screen or kind of prevent it, and therefore making the whole process safer and hopefully more sustainable. Now, this is the life cycle of what I call a safe vaccine, but it's true of any safety concern. You start off with a case report of something that occurred. You do some kind of standardized assessment, and hopefully you build up a case series. And then if it looks like it's plausible and kind of ruled out alternative hypothesis, you move to a control study to establish whether it's real or not. And then there's 3 different outcomes for that. At the end of that, you have some data, some evidence that you want to communicate to both the society, advisory groups, as well as patients and their doctors to make the risk-benefit policy. You hopefully could understand the pathophysiology and risk factors from further studies, and they'll impact on the ability to either treat it, to compensate it if it's truly due to your exposure. You might be able to develop a safer vaccine, develop appropriate contraindications, and then again, screening for that. Now, the problem is that the first step is doing some kind of adverse event report. And so a few slides back, I showed you that in the U.S. passive system, there are about 38,000 reports a year. Now, the problem with those reports, and I'm going to show here, is that in the vaccine domain, the way we establish a causal link is that if you had a unique laboratory, and I should just say that in your field may not be quite as challenging, but in the vaccine field, if we had unique laboratory results, so somebody received a viral vaccine and developed meningitis, you do a spinal tap, isolate the virus and do genetic sequencing and show that it's the vaccine strain, not the wild type. So you have done that. Or that if it's a relatively unique clinical. So a few years ago when they restarted smallpox immunization in the military, in healthy young recruits, they started to develop myopericarditis. And these are healthy 20-year-olds who normally don't walk around with that problem. And so that's a relatively unique syndrome. But if you lack either of those, you're going to have to do either an epidemiologic study or a very large clinical trial, completing all 4 cells of this 2x2 table, vaccine or drug exposure, yes, no, and illness or syndrome, yes, no, in an unbiased manner, and then you do your rate and calculation and see if the vaccinated people got a higher rate or not. And in the past surveillance system that I talked about is actually just cell A of that 2x2 table, people who have vaccinated and had the illness or syndrome. And even then, it's a very biased group. There's underreporting and there's biased reporting. Those who had the adverse event more proximate timing-wise to vaccine exposure more likely to report it. So you have less than a quarter of the scientific content needed to make your calculation. And so less than a quarter of a hand clapping is obviously not very, very loud. And so the work in vaccine domain that I focused a lot of my effort on was to then see what we could do to collect all 4 cells in an unbiased manner. And we went to health maintenance organizations that were kind of vertically integrated at computerized vaccination records, different health outcome files, and different patient characteristics that we could use to control for confounding, and used it for linking Now, the problem obviously is that in less developed countries where computerization is less prevalent, that will be a challenge, though obviously with increasing access to mobile phones, etc., some of these issues may start to be solved. And at that time, it was called the Immunization Safety Branch. We created different pieces of the infrastructure to answer specific pieces of this larger puzzle. So we had a passive adverse event reporting system for hypothesis generation, answering the question, could vaccine possibly cause the adverse event? We had two hypothesis clarification systems. One that this Brighton collaboration focused on trying to standardize case definitions, because if you're looking at multiple different outcomes and didn't standardize a case definition, so something as simple as fever, do you measure it in Fahrenheit? Do you measure it in centigrade? Do you measure the temperature under the tongue, under the armpit, or in a baby in the rectum? Do you measure it at 24 hours after vaccination, at 42 or 72? And it turned out that historically, none of that was standardized. And so if your goal was to detect a rare outcome, in fact, the system was designed to make sure that, in fact, you would miss it due to heterogeneity. And then the other components, this vaccine safety data link with the databases allowed you to actually test the hypothesis. We needed a group on how to disseminate the information to deal with risk perception and communications, and then a group focusing on vaccine technology and how to make things safer. So this starts to be kind of the piece of a larger system, if you will, that could start to tackle some of these larger challenges. Now, in a developing country setting, whenever you do a mass campaign, and so in vaccinations, we do that, as you all do in NTD as well. And when and if there is a problem, so here in Brazil, they used a mumps vaccine strain, Leningrad Zagreb from the former Soviet Union, that had a known rate of vaccine-associated aseptic meningitis of 1 case per about 3,400 doses. And sure enough, during the campaign, you see this outbreak of aseptic meningitis. So that's kind of what you expect. And so in 1976, 77, in the swine flu campaign in the U.S., we had a similar story with the Guillain-Barré syndrome. And so these days, be it the polio, be it the measles campaigns, they spend a lot of time planning for adverse event AEFI, and I don't have time to go through all this, but there's a whole set of literature to help with this campaign and how to prevent loss of confidence, because obviously these clusters are very visible. You'll hit the media right away, and you're done for unless you manage it properly. It's been seen that because at this point we don't have the ability to predict which of the people we universally recommend or require immunization will actually develop the true vaccine reaction. And especially in countries historically like the U.S. without a national health insurance, these families were left bearing the burden. And so back in 1986, the U.S. finally passed a Vaccine Injury Compensation Act, and the thought was that since the public good acquired firm protection against these vaccine-preventable diseases accrued to the general public, that all of us should then pay a certain excise tax, or I think at the moment it's like 5 cents per antigen, that goes to a trust fund that then, in theory, is supposed to be applied for no-fault compensation of people who have vaccine injuries. I'm going to stop there. I have a bunch of other extra slides, but David wanted to save enough time for us to discuss, and I'll use those as needed. So let me just... Thanks, Bob. Yeah, so yes, we do collect it. So part of the 86 Injury Compensation Act covered multiple areas of the immunization domain, and at that time, the FDA had its own phase 4 surveillance system, and CDC had its own for public sector, and the two had two different forms, and we actually didn't know what was going on in the country. So it mandated reporting of certain adverse events, and we decided to work together with the FDA to create VAERS, and as part of VAERS, then whatever the companies report to FDA then is also part of the VAERS database. And we track who the source of the reporter is, so you could segment that out. And the data is actually available to the public, open access, and it actually has a fairly user-friendly report-generating function called Wonder. And the companies also use that same database to download for their analysis. Yeah. So the first step in that is obviously to get folks to record the lot information in the immunization record, and that has been problematic because, as you can imagine, the lot number is a long string of nonsense alpha numbers, and this transcription error is probably on the other 10 to 15% in the database. We've been working to get the companies to put small barcodes, kind of two-dimensional, let's see, yes, two-dimensional barcodes on those small glass vials, and there's a demo project going on at the moment. And so in each of the main databases, both the passive and the active surveillance systems, they do track lot numbers now. And in the HMO type databases, the quality is definitely much greater because it's just entered the system once. And at the moment, the FDA does look at that regularly. I guess for the moment, we have not that I'm aware of, withdrawn a specific lot due to a specific problem. Now, back in, I want to say, when we started about 30 years ago, there would be occasional clusters of sudden unexplained infant deaths. And frequently, the knee-jerk reaction is just, okay, well, let's just pull that lot just so that we reassure the public. And then later on, it turns out not necessarily to be the problem. And I would have to say that generically in most countries, that is still kind of the modus operandi, and hopefully one day we'll get to a true scientific basis for lot-specific studies. Yeah, so we're not there yet, and let me kind of jump ahead to, so in general, any of you who have taken science classes know that most things in science are in a normal distribution. And so similarly in immunization, the biologic response, both in terms of immunogenicity and reactogenicity, is probably in some kind of bell-shaped curve, where some people under-respond, some people over-respond, most people are in the middle. And traditionally, these people who under-respond is very straightforward. You just give them more doses of the vaccine schedule. Our problem really has been this flip side on the far end. We actually didn't know how to predict who's going to end up on this side or what to do with them. And due to that kind of lack of ability to adequately deal with it, frequently kind of get swept under the carpet a little bit, I would say. And so how does one build additional evidence? And used to be that I would sit at CDC and I would pick up the phone, and on the other end would be a clinician or parents saying, you know, what do I do in this situation with the next dose? How can I treat it? And I realized that sitting on my desk, actually, I I didn't have the scientific evidence to actually support anything I was saying. Okay, and that and this is a inherent problem. That here's the issue: adverse events occur rarely for each clinician. They're medical outliers, and they're difficult to advance the science on. And how do we do this in general for orphan diseases? Leukemia used to be universally fatal, but nowadays is treatable. Okay, and part of it was that we didn't expect the average primary care physician to advance the science of leukemia. Right? We established tertiary medical centers on a regional basis where enough cases of rare leukemia could be referred, and then you could actually conduct clinical trials and see which things worked and which things didn't work. And same thing in vaccines. We've been immunizing since Jenner, and yet we never established anything like that. So the primary pediatrician out there is expected to advance the science of these rare outcomes, and that's not going to happen. Okay, so I created something called the Clinical Immunization Safety Assessment Network, CISA, where these are academic centers of excellence, vaccine safety clinicians with kind of clinical subspecialty and laboratory, so that over time they could do the same thing. They could advance the science of it. Standardized assessment of either known reaction, suspected new syndromes, next dose in patient with a prior VAE, real-time consult for clinicians, and then follow-up for compliance and outcome. What happened to each of these onesies and twosies, and then over time we could do that. So we increased scientific understanding of these outliers for immunology, pathophysiology, genetic or other predisposing factors. And one would suspect that the various reports, those 38,000 reports annually, are probably overweighted on that far right side of that bell-shaped curve. And so that's low-hanging fruit that we could actually learn from, rather than just accumulating dust in this country and every other country's database. So it will maximize our utility, use it as a disease registry, hopefully disseminate protocols, findings, create a new subspecialty. So the societal problem is actually a fundamental one, and one insight is that currently what happens is that if you, well, let me take a step back. So one day I thought, are people born anti-vaccine? And I said, no, that's not true. Most people in general kind of, they go to the pediatrician, tend to have a good relationship, but at some point, how is it that they wound up on the other side? Okay, and I said, well, maybe this is what happens. If that they were unlucky to have an adverse event and go to the doctor the next time and ask a very fair question, Doc, should I get the next dose? I had this problem, right? They could, so it's at the individual level, it's a perfectly rational, reasonable question. But at the societal level, in that practice, they might say, geez, this person's hesitant about their next dose of vaccine. And maybe they're anti-vaccine. So the dynamics may start to kind of go astray from a purely kind of innocent situation. And so in the future, rather than this kind of win-lose, we could shift it to a win-win, where we treat the individual rather than the average patient to actually do, nowadays we have personalized medicine to actually get away from everything being exactly the same. Now this is still a long road to get us there, but at least it starts to kind of frame the issue in a different framework. So you have kind of a destructive labeling of them as an anti-vaccine or vaccine hesitant, when all they're doing is just asking a perfectly logical question, do a constructive collaboration. We immunize more safely versus just immunizing more. And then I think many of you have heard of this researcher by the name of Andrew Wakefield, who raised this whole false concern in retrospect about autism, etc. And I actually followed him before he raised this in terms of thimerosal, because he was actually a GI, he was a surgeon, and at one point he was interested in inflammatory bowel disease. and he raised the question, well, with measles, some people develop kind of chronic infection with measles, and maybe the inflammatory bowel disease is due to that. So the perfectly logical scientific question. And so, and then at some point he kind of was looking for more funding and went astray. But if we had a safe harbor for these type of questions, then you won't risk these people kind of winding up, on the front news to try to get their own funding. And so several countries actually have CISA type special immunization consults to deal with people who are hesitant, and I think this is potentially a way forward. So scientifically, to answer your question, we're not there yet, but at least the framework could be there, but funding is a challenge because, unfortunately, in those early days of the immunization program and the injury compensation program, it's a long story, but at that time we were using a wholesale pertussis vaccine, the DTP vaccine, which caused a lot of fever, a lot of seizures, etc., and people thought it caused kind of brain damage. And at some point there was one of those news reports or 60-minute type stories, and so there was a massive loss of confidence in multiple countries. In the U.S., we didn't lose the coverage that much, but we had a huge increase in lawsuits. So every single manufacturer dropped out of the market except for one single manufacturer, and the vaccine price, as you imagine, went up tenfold. And so Congress says, geez, we got to do something, otherwise the whole thing is going to collapse. And so an unusual coalition of the parents group, the vaccine pharma, and the American Academy of Pediatrics passed a law on injury compensation over the opposition of the government. So interestingly, at that time, the department says vaccines are safe. We don't want to say that they're unsafe, so we will oppose this bill. And to their credit, they formed a coalition that passed it over the opposition. But that was one of those years where apparently President Reagan would have vetoed the bill, but there was an omnibus budget bill that if he didn't sign, the government would have closed. And so that bill was attached to the omnibus budget, and so he was forced to sign it. But then during the implementation, rather than it being a no-fault compensation program, the Department of Justice and the Department of HHS fought each case tooth and nail. So that over time, I think currently a $2 billion surplus has built up in that trust fund. Okay, and the sad thing is that with other excise tax programs, for example, airport, every time you fly on an airplane, you pay an excise. And that goes towards improving the runways, the radar, etc. It doesn't go just to pay for airplane crash victims, which the original framers of the Injury Compensation Act said this trust fund should go as much to prevent vaccine injuries as it is to pay for vaccine compensation. And because of that opposition from the government, the parents groups have kind of gone way out and said, don't you dare touch that money for anything. That's money that belongs to us, right? And so we're caught in this incredibly difficult, silly, stupid political thing, especially in this era where the science actually wouldn't allow us to finally answer some of the same questions that they want to also answer. So there's room for potentially a political deal, but it requires some real big steps, hurdles to be overcome.
More. Thanks. It's a great question, and I think you're talking about the so-called chewable formulation of albendazole, which is actually larger than the old formulation. And for those of you who don't know, this is a tablet that if you add a little drop of water, it turns into a nice putty, and it's very soft. When I was at CWW, I expressed concern to J&J about this because if it is swallowed without the water, it seems like there may be just enough moisture in the trachea and it's large enough to completely obstruct and then turn into a nice little plug that will completely be unable to be dislodged, even with CPR or Heimlich maneuver. So I expressed this concern. It was decided not to do those studies, and in fact, this one study that I reported hadn't been done yet. They had done some safety evaluation, primarily on the pharmacology, and in the clinical trials, they excluded children who were crying and were fussy, and so it was very carefully controlled, and those were situations that could be difficult to replicate during mass drug administration. So I don't know. I'm concerned about this new chewable formulation, that it hasn't been tested in the reality of what mass drug administration is in certain settings. So I share your concern.
So at CDC and most countries now, there's a advisory committee on immunization practices, ACIP, and it's got about I don't know, 10 or 15 official members that sit in these rotating cycles, and they're advisory to the director of CDC. And those of you who are old enough, there's actually a second role of this committee. Back when President Clinton tried to introduce his healthcare reform, and that failed under Hillary and others, there was one piece that survived, was something called the Vaccine for Children program. And what that is, I think it's one of the few things in the U.S. government in which, as long as the ACIP makes the recommendation that this new vaccine should be a routinely recommended vaccine, then automatically the cost for it will come from the Treasury. It doesn't require a separate appropriation every year as normally you do for most other legislators. And that committee usually, in anticipation, I would say maybe a year or two ahead of the actual submission for licensure, because many of these products obviously take 10 or 15 years to develop, we'll actually start to constitute a subcommittee and then start to talk about what are all the different issues we would want to include in our official recommendations and guidelines. And it's a pretty standard format. So for each of the vaccines, there's a pretty lengthy document. And they try to time it so that on the same day that FDA actually licensed that new vaccine, that these recommendations are also published at the same time.
If I could just jump in on that, and then I think what's interesting to me is the difference in culture between the NTD community and vaccine. The ACIP deals with not only efficacy, but also to a large degree with safety. And I think maybe we've been lulled into a false sense of security by the safety of our drugs. We don't have that same preoccupation with safety that vaccines do. And how to generate that, I think, is one of the challenges we have now.
Yeah, so it kind of went up nicely in a nice curve, just purely kind of graphically. But in reality, obviously, it will vary. Now, the good news is that in general, these are kind of self correcting cycles. So, as I mentioned, that loss of confidence in the wholesale DTP vaccine occurred in multiple countries, Sweden, Germany, England, etc., and kind of massive resurgence of disease. And when a new, safer acellular pertussis vaccine was developed and went through the phase 1, 2, 3 trials, etc., and each country had them, then the uptake kind of went back up, and then those diseases kind of went back under control. And similarly, when Wakefield was at his height in UK, and I guess UK preceded US in terms of kind of the fake news and kind of tabloids, etc. And so the measles vaccine uptake kind of took a real dive, and they had their measles resurgence as we are having now, and then ultimately, kind of due to a combination of vaccination and wild disease-induced immunity, kind of measles came back under control. So there's no super lesson in terms of guaranteed resumption. You just, people do their best, and hopefully, the disease rates when they go back up, the media does report on them, and people, just similar right now in New York, even some of these orthodox groups, hopefully, some of them are starting to get immunized as well. This, I think you saw in that diagram of the immunization safety branch, there was a group on risk communications. And that was when so that was back about 20 some years ago when we did not have risk management strategies deployed, as you said. And I hired a couple behavioral scientists, and they went and started to look at the literature, and they noted that basically what happened was that the nuclear energy folks were probably one of the first ones to confront this issue of where the public perception of scare, of fear, was greater than potentially the real day-to-day fear, and they had to develop a whole strategy, and they started to research people's understanding of and perception of risk. And so there's actually a very rich literature in that domain now of what are the different characteristics that make a risk more scary. Is it more is it more natural, quote unquote, or is it more kind of man-made? There will be one nature of it. And so again, I think luckily in the NTD domain, your interventions are more straightforward, whereas in immunizations we have some pretty complex. Many of the new vaccines against Ebola or these exotic pathogens are kind of complex viral vector constructs in which the genes manipulated, in which there's not necessarily as much kind of actual experience, where you're dealing with pills by and large or variation on that. And but definitely, I think risk management plans are good, and then understanding, spending some time in the kind of understanding people's perception of risk, and then it's all stratified by are you dealing with kind of uneducated person or somebody with at least a baseline education or college. All those require different messaging, and so much of our immunization communications almost kind of first ask them, well, are you a provider or are you a patient? And then, what's your background in order to target the right information for you.
Yeah, I think we need more information on what actual practices are. And particularly in the case of the new chewable tablet, I think some more intensive observations of do children have difficulty with this, and under what conditions can it be delivered safely? I think that would be my recommendation. But I think as we get into more integrated NTD environments where multiple drugs are given, I think we need quite a bit more observation to say, are the doses being given properly? If you crush tablets here, but you're giving oral suspension there, and how is that actually being done? Are those messages being carried through to the community drug distributor? So I think much more observation about what are the messages that will promote safety, and are they actually being carried out and delivered? I think we need that kind of information. Yeah. So we're actually trying to get some funding for expanding these sort of observational assessments in other environments. Yeah. thank you very much, everyone, for a great discussion. Thank you.